Welcome back. I hope that everyone is inspired by our start of our day, and I'm sure some people will continue to drift in. So I'm Marion Henry. I'm the APSA Program Committee Chair, and our session this morning for Scientific Session 1 follows the theme of our keynote address and is focused on advocacy topics. It's an honor for me to introduce our moderators. Dr. Suzanne Yoder is a locum tenens pediatric surgeon working at multiple sites in Arizona, California, and South Dakota. And Dr. Chinwendu Onwubiko is an assistant professor of pediatric surgery at the University of Alabama. Our chat moderator for this session is Dr. Marissa Schwab, who's a pediatric surgery fellow at Lucile Packard Children's Hospital at Stanford University. If you could use the QR code on the screen in front of you to check in for the session. This is being used for our evaluations of the sessions. And at the end of the session, please, in the Whova app, go to either the rate session or the evaluate or feedback for session to give your feedback for these sessions. And these QR codes will be at every session that you attend through the meeting to help us gather more information about how we learn and how we can improve the APSA meeting. And with that, I will turn it over to our moderators to get us started on scientific session number 1 on advocacy.
Good morning. Our first speaker is going to be Dr. Heather Hartman, who is from the University of Michigan. She'll be discussing the understanding contextual factors influencing firearm deaths occurring among children.
So I definitely had a great lead into this, so thank you for letting me present today. I have no disclosures. The circumstances surrounding firearm deaths in children 0 to 10 differ from older children and have been minimally studied. Our research shows that deaths among children 0 to 10 years of age have a distinct set of patterns and have identifiable opportunities for prevention. Firearms remain the leading cause of death for children. Just 7% of firearm deaths in children occur in children less than 10 years of age. Yet among this group, unintentional deaths are a significant portion. This study had 2 primary goals. First, to describe and contextualize the firearm-related deaths in children ages 0 to 10, and second, to conduct a cluster analysis of these contextual factors, identifying groupings of similar incident factors to inform prevention efforts. Review of a national child death database was conducted for firearm deaths of children ages 0 to 10 from 2004 to 2020. Descriptive analyses characterize the child, the caregiver, and the incident. Using contextual variables, cluster analysis was performed. Cluster analysis is a data-driven, iterative process that identifies natural groupings by their similarities, much like a taxonomy tree in biology. There were 1,582 child firearm deaths in our study period, of which 74% had complete data. Excluded patients were excluded for not having information on firearm type, supervision, and firearm use. The mean age was 5 years old, and 63% were male. 41% were white and 35% were black. 9% had a history of CPS involvement at the time of death, and 19% had a history of child maltreatment. The child's primary caregiver was a parent in 93% of cases, and almost 20% of caregivers reported a history of intimate partner violence. When we look at the incident details, we see that just under 40% of deaths occurred in urban areas. The most common location was the child's home, with 85% of children dying in their home or a friend or family member's home. And 75% of incidents had a supervising adult at the time of death. 81% of firearms were handguns, and 65% were owned by the caregiver or another family member. The most common firearm uses during the incident were crime, playing or showing a firearm to someone, and self-injury. Notably, child abuse in IPV was associated with 16% of cases, and 9% were murder-suicides. Turning now to our cluster analysis, we look for grouped variables. In this first cluster, we see the grouped variables of gang-related, drive-by, and random that happens outdoors. Next, we see deaths that occur using long guns while cleaning, hunting, and target shooting. Bystander child firearm deaths clustered with IPV, abuse, arguing, and jealousy. Another distinct cluster involved those within the child's home while the child was supervised by an adult and using a handgun. Some of these were a crime, which may include unintentional discharges where an adult was charged with negligence. Within the larger in-home cluster were murder-suicides. Finally, there was a cluster of unsupervised deaths that occurred in a friend or family member's house while playing or showing a firearm to others. So in conclusion, we identified 6 distinct clusters of firearm deaths in young children. The first 3 can be grouped as related to unintentional causes, highlighting the importance of child's developmental stage when considering firearm access, secure storage, and the need for careful supervision during firearm use. These clusters raise concern for violence within the home. Situations where CPS is involved or where there is identified IPV represent missed opportunities for prevention. Providers and CPS workers are critical elements in this prevention, in identifying the IPV, and providing education both on safety planning and on secure firearm storage. And finally, community violence disproportionately affects our Black children living in urban settings with a legacy of redlining and economic disinvestment. HVIP's community-level interventions and policy-based initiatives may be effective at reducing community violence and bystander child firearm deaths. Thank you.
Question? Are there any questions?
How are you broaching the subject of guns in your practice?
So right now at our institution, we don't have a standardized protocol. We're actually working to implement an RCT in our pediatric emergency medicine department that is going to be the enhanced usual care of offering a pamphlet and a gun lock to individuals who report firearm ownership. And then having 2 additional arms, one with a trained therapist to do a motivational interviewing to try and enhance secure storage, and the other using in ED firearm owning emergency techs to help do that same counseling to see if we can deliver the same message and whether there's credibility of our trained therapists as compared to the techs who are firearm owners.
That sounds like a great rollout. Any other questions? Thank you very much.
Thank you.
Our next presenter is Dr. Emma Komel from Northwell Health Center for Gun Violence, talking about examining preliminary uptake of universal screening for firearm injury risk among pediatric trauma patients.
Good morning. Thanks for the opportunity to share our work. So I have no disclosures. Dr. Sathya has the following disclosures. So I don't need to tell this room, especially after our fantastic keynote speaker, that firearms are the leading cause of death for U.S. children and adolescents. And at Northwell, we really believe that hospitals and health systems offer a unique opportunity for firearm injury and mortality prevention strategies. We also know that pediatric healthcare providers routinely do screen for a variety of health concern and then subsequently provide anticipatory guidance and appropriate educational resources to promote health and safety. And so because of this, we believe that pediatric hospitals are optimal environments for implementation of what we call FIMP strategies, or firearm injury and mortality prevention, as part of usual care. So in 2021, our health system implemented a universal FIMP screening program as part of some NIH-funded work at 3 level 1 trauma centers in the emergency department, And the goal was really to normalize the conversation about firearm safety and violence risk for our patients, for caregivers, and for healthcare team members, and provide appropriate resources whether they screen positive. This effort was based on principles of harm reduction and lessons learned from a very successful implementation at our health system of a screening and brief intervention referral to treatment program, or SBIRT, for alcohol and drug use. So one of the precipitating factors for this particular presentation was we saw at our children's hospital a massive increase, nearly 360%, in the number of pediatric gunshot wound injuries that were coming in. And when we did a retrospective chart review of all of these patients, one of the things we realized is that our universal screening program done in the emergency department was largely missing all of these high acuity, high risk trauma patients. So what we ended up doing was we started this new program called EFIMP, or Electronic Firearm Injury and Mortality Prevention, in March of 2023. And what we did is we worked with the Pediatric Surgical Service to integrate this FIMP program into the tertiary trauma survey that all pediatric residents completed. The surgical residents received instruction from the pediatric surgical fellows on how to do this. It was integrated into the EMR, and it was through REDCap. And then they were given guidance from our clinical research program manager on how to utilize the tool, the appropriate documentation in the EMR, and then the available resources, because it's one thing to screen patients, it's another to provide the appropriate resources. And we felt that this was really important because there was a large percentage of patients who were being missed and who would really benefit from appropriate referral to community resources, in particular among those with violent injuries. So our inclusion criteria was patients ages 12 or older who were admitted to the pediatric surgical service and or for whom a tertiary trauma survey was performed. We had 169 patients total between March of 2023 and March of 2024. You can see that 17, or about 10%, were screened in the ED, so a very small percentage, again, demonstrating that we are missing a large portion of these high-risk patients. 88, or 52%, were screened by surgical residents, which is fantastic. And then 64, or 38%, were not screened, and that was due to these patients being intubated, being altered, and unable to answer questions. But the big takeaway is that overall, 62% of these very high-risk patients, so patients who have been assaulted, who have been stabbed, who have been shot, are getting the screen and the intervention, which is really good news. You can see here, this just shows the screening over time. The orange represents screens done by our surgical residents, and you can see that they are consistently screening patients over time, which is wonderful. These demographics are pretty unremarkable. They reflect what we typically see with pediatric trauma patients, but again, just important to demonstrate, obviously 65% of patients who screened were male and 22% were female. So in conclusion, we think that this is a really promising tool to identify and then subsequently provide appropriate resources to patients and families to increase safety and reduce the risk that's associated with firearm access and risk of violence, and that integrating it into the tertiary survey is actually a really sustainable way to make sure that patients are getting this service and these questions and the appropriate intervention. Factors associated with screening were championship by surgical attendings and fellows who provided daily reminders during morning rounds, which really did help to increase utilization. So overall, the sort of impact of this effort is really that we have begun to ask these questions and offer educational and safety information, provide the resources to ultimately increase safety behaviors and decrease overall firearm injury risk. I'd just like to acknowledge the Pediatric Surgery Department attendings, fellows, and ECPs who all helped to facilitate the implementation of this, and our trauma program manager who provided all of the trauma registry data. And I'd be happy to answer any questions you have.
I've got a question.
Hi, Chris Newton from UCSF. So you mentioned at the top that some of the inspiration, I guess, stemmed from your SBIRT screening program. At the end of this, how in your institution are you integrating the other screening programs into one unified kind of something? Are social workers getting overwhelmed? Nursing supervisors are getting overwhelmed. They're being asked to do suicide screening and mental health screening and PTSD and drug and alcohol and now firearms. How are you putting it all together?
So I think that's the value of utilizing the tertiary trauma survey, is it does take some of that sort of weight off of the social workers, but we also at our hospital have a hospital-based violence intervention program, and so our staff who work with patients who are violently impacted are also doing this survey, and I think that does sort of help to disseminate some of the burden, but you're completely right. Particularly our social work colleagues are very overburdened, and I know there's been a new ACS requirement to start doing screening for PTSD, et cetera. And so our goal is to not overburden, but rather to kind of share the love, but make sure that these patients ultimately do get the questions and the appropriate intervention.
Good morning. Thanks for your presentation. Rami Jamshidi from here in Phoenix. I'm curious to know if you picked up in the course of this study any sense of pushback or resistance to the screening questions, particularly from the families.
So actually, we had only one family who refused to answer questions. I think that's in large part due to what you can see on the screen right now. We've done a really good job as a health system of promoting this initiative. So you can see everyone wears these orange shirts. There's signage all over the hospital. So it's more normalized, I think, than perhaps in an institution where this is a very new topic of conversation. But I was also surprised that we only had really kind of one significant pushback, and the rest, it was just sort of looped into usual care.
One more quick question.
It'll be quick, thank you. Great work, and it's super important to implement screening universally in this fashion. Interested in learning, understanding what you guys are doing to assess and evaluate whether it's actually working.
Yeah, so we've just begun that process. We are about to start kind of evaluating the impact of the linkage to care that we're doing, as well as the intervention resources to really determine how effective they're going to be. So it's ongoing. Stay
And the
tuned.
screening, just so I understand, it's not just asking about how guns are stored, but it's also about violent behavior
Yes,
risks.
so we use the safety score
Yeah.
to determine violent
Okay,
risks.
so it's not necessarily just for firearms, it's also for
Risk of
assault
future
and
violent. Yep,
fighting
exactly.
and stuff like that. Cool,
Exactly.
thank you.
Thanks so much.
Our next speaker will be Dr. Pamela Amingo. She will be speaking about the profile of mass shootings from 2009 to 2021 and their impact on children.
Hi everyone, my name is Pamela Mango, and I'm going to talk about our work on mass shootings and how it impacts children. We have no disclosures. So I did the research, and I think it's important because in 2020, pediatric firearm injuries increased to become the most common cause of death in children in the United States. This is a figure from a 2022 article that summarized CDC data showing that motor vehicle crashes became number 2 as firearm injuries became number 1. This is another figure from the same article that indicated that homicide was the most common mechanism of firearm death. When the authors compared 2019 to 2020 data, there was a 33% increase in homicides from 2019 to 2020. Right now, it's not clear why this is occurring or how we can prevent it, but what we do know is that firearm deaths is a uniquely American issue. This is a graph that shows how America is the leader of firearm injuries when compared to similarly developed countries. This next figure shows that when it comes to children, Americans die compared to high-income countries and compared to low-income countries. America is the number 1 cause of firearm death. Despite gun violence being a significant problem, research lags behind the major causes of death. This is a graph that shows that there's fewer research publications on gun violence when you compare it to other causes of mortality, like falls, motor vehicle crashes, and poisonings. We need more research on firearm deaths, especially when it involves mass shootings in children. We focus on mass shootings because even though they make up a small proportion of the children killed, they are very influential and oftentimes symbolic of American gun violence. Despite the influence on public perception and gun legislation, we have little information on what actually works to prevent child deaths. Our purpose was to characterize, quantify, and illustrate the trends in mass shootings involving children. So we used the Everytown for Gun Safety database from 2009 to 2021. We quantified the deaths of children killed by mass shootings. Children were defined as aged less than 18, and we defined mass shootings as 4 or more victims killed, excluding the perpetrators. There were 267 mass shootings during this period, and children involved 50% of them. Of the adults and children injured, children accounted for just 16%. But in 133 pediatric mass shooting events, there was a death in 131 of them. A total of 328 children died, and domestic violence accounted for 73% of this. This is a figure that highlights that shooters knew the victim or were related to them in 73% of all of the mass shooting events. Of the 50 states, 5 did not report a mass shooting during this period, and 9 states did not have a mass shooting death. Texas, California, and Florida had the most incidents, while Texas, Florida, and Connecticut had the most overall deaths. When we adjusted the population of each state to the amount of children less than age 18, we saw that Connecticut, North Dakota, and Wyoming had the highest adjusted death rates. Our data analysis was largely limited by the granularity of our data set. The data was driven by perpetrator information rather than victim data. So data regarding sex, race, and relationship to the shooter was not included in our analysis. In our future work, we found a new data set where we will analyze this victim data. And we also plan to see how state legislation plays a role in mass shootings. Our big takeaways are that children account for 50% of mass shootings from 2009 to 2021. Domestic violence plays a large role. Our future efforts will aim at reducing gun access, particularly in patients who have suffered from domestic violence or related to it, so that we can prevent pediatric deaths. These are our references, and thank you for your time.
Do you have any questions? I do have a question about the locations of some of these events. I think it's a little interesting that Texas and California are both the highest, but they have very different gun laws. Do you have any thoughts about that?
So we have a figure that we're going to present in our paper, but it shows a distribution of all the gun deaths and gun incidences and the adjusted rates. So Texas has a high percentage of gun deaths and incidents, while California has a lot of incidents, but very little gun deaths. And in terms of firearm strengths in their laws, California is one of the stronger law sets of preventing gun violence, while Texas falls more on the looser ends. But that's an upcoming work where we go into detail on the strength of gun legislation and which laws actually can prevent mass shootings.
Thank you. Thank you.
Thank you very much.
Thank you.
Our next speaker is Dr. Shelby Kirkendall. Her topic is Youth Firearm Hunting Laws in the United States, an opportunity for standardization of safety training and supervision requirements.
Hi, good morning. My name is Shelby Kirkendall, and I am a general surgery resident and also finishing in my postdoc years in research at the American College of Surgeons as the Firearm Injury Prevention Clinical Scholar. These are my financial disclosures, and this is my non-financial disclosure. I myself was a youth hunter. This is me around 4 or 5 years of age. And as for my family and I, hunting is a very valued tradition in the United States for many families. And in 2021 alone, 15.2 million individuals went hunting, of which 1.2 million were youth hunters. And while many children are taught firearm safety rules when they're learning how to hunt, it's not really standardized of when and how those rules are taught. Additionally, it's up to supervising adults as of now of what children are taught and if they're even supervised at all. So we set out to identify youth firearm safety training requirements and adult supervision requirements for youth hunters. We decided to look at all 50 US state regulations with the hopes of creating evidence-based guidelines to further standardize regulations for youth hunters and safety training requirements. The objectives: one, were to evaluate firearm safety training requirements and adult supervision requirements for youth hunters. We conducted a cross-sectional study of all 50 US states' hunting regulations from July 2023 to December 2023. We used state government databases for the main source of our data. And the data that we excluded included Washington, D.C., as hunting is not permitted within city limits, and any regulations specific to youth hunting days, as these often differed from generalized state requirements. For hunter safety training requirements, we found that 22% of states listed here in green unconditionally required youth to take hunter safety. 76% of states listed in yellow conditionally required youth to take hunter safety course unless they were with a supervising adult. And one state, coincidentally, the one that we're in right now, had no requirements for youth to take firearm safety training. While most states required youth to have adult supervision at least until they were over the age of 16, about 40% allowed youth to go hunting unsupervised under the age of 16. And to orient you here, the states in gray had no requirements for adult supervision for youth hunters. States in yellow allowed youth to go hunting unsupervised between 13 and 15 years of age. States in orange allowed youth to hunt unsupervised between 11 and 12 years of age. And states in red allowed children to go hunting unsupervised at or under 10 years of age. And with the variability in state laws that we saw, there's really an opportunity for a collaboration between state agencies, hunting and conservation departments, and medical organizations to create minimum standards for youth hunters and their safety. Additionally, future work in this field, our next steps are to look at unintentional hunting injuries for youth, and also looking at those states that have stronger or more lenient hunting regulations. And I'd be happy to take any questions.
Thank you, Shelby. That was really interesting. I do have a question. Which of the two do you think is more important? Do you think the adult supervision is more important, or do you think the regulations and the training are more important in youth hunting?
That's a great question.
Thanks.
So I guess I'll answer your question with a statistic that we found, which is that supervising adults, some of them were able to be under the age of 18 years of age in many states, and also requirements for the supervising adult were often, about 60% of the time, was hunter's education. And so I think like a standardized hunter's education, even in the states that conditionally allowed children to hunt unsupervised, you know, it's a hard toss-up of which is the more important one, but I think that starting with a standardized education is really the first starting point in making this standardized across the country.
Awesome. We have another question.
Hi, really interesting talk. Following up on your comment about hunter education and standardization, how do we determine which parts of education are actually effective for our youth and also for adults?
That's a great question. I think that that's going to really come from a consensus statement and evidence as far as developmental pediatrics and including hunters in the conversation and hunting organizations of when children are appropriate to go forward with what age they should get hunter's education, what age they should be allowed to hunt unsupervised. So I think that it's really bringing everyone to a seat to the table to kind of make those decisions.
Great presentation, Tim Otts from Chicago. Do you have any data correlating the strength of the rules with hunter accidents or near-miss episodes?
Great question. That's our next step, is looking at those data. There are publicly facing data about hunting injuries, unintentional hunting injuries in a lot of states, but not every state. But we're in the process right now of collecting that data and looking at states with those stronger or weaker hunting regulations for youth.
Do you have any information about the actual enforcement of these laws?
Another great question. That's the hard part about this, is that we looked at the laws, but that doesn't mean that that's actually happening. And I don't have an answer for that right now of how are those laws enforced, but that is a great question to look at in the future as part of the study.
Thank you so much.
Our next speaker will be Dr. Allison Lehane from Northwestern Hospital. Less is more, optimizing surgical trays, reduce cost and environmental impact.
All right, thank you so much for the opportunity to present. We have the following funding disclosures. So to address the whys of this talk, it's important to discuss that climate change, propelled by atmospheric greenhouse gases, is a global public health crisis. The healthcare sector is responsible for 10% of all US GHG emissions and continues to lag behind other economic sectors in sustainability reporting. In fact, if the US healthcare sector were ranked as its own country, it would rank 11th worldwide. The conventional methods of instrument sterilization, including cleaning, autoclaving, and chemical disinfection, entail energy-intensive processes that contribute significantly to greenhouse gas emissions. So the purpose of this study was to perform a comprehensive examination and subsequent optimization of pediatric surgical trays. Specifically, we aimed to update the surgical tray options by optimizing the tray types with the guidance of key stakeholders, such as attending surgeons, OR nursing staff, and surgical technologists, to then quantify the impact of the changes in terms of cost and GHG emissions. Our institution is an urban freestanding academic children's hospital with 13 pediatric surgeons performing between 3,000 to 3,500 cases annually. A comprehensive audit of pediatric surgical trays was conducted, involving collaboration with surgeons, nurses, and surgical techs under the direction of our Center for Quality and Safety. Utilizing an iterative process to gain consensus, trays were redesigned based on the findings of the audit, with the focus on eliminating rarely used items and decreasing unique tray types. To quantify these changes, the cost of sterilization was determined using an industry standard of 66 cents per instrument, as reported in other literature. And to quantify the GHG emissions, this was calculated using 77 grams of CO2 equivalents per instrument, utilizing data from a singular European study on the environmental impact of sterilization. Prior to optimization, there were a total of 7 unique tray types, which was reduced to 3 by condensing 5 of the unique tray types to 1 pediatric mini tray. Each unique tray has multiples ranging from 10 to 2 depending on the tray type. This revealed 35 total trays pre-optimization, able to be reduced to 32 total trays post-optimization. The total number of instruments was decreased from over 3,400 to just over 2,800. Based on annual surgical volume and tray usage data, the sterilization cost was decreased by over $40,000. This reduction in cost is attributed to the streamlined trays and the decreased number of instruments requiring sterilization. The environmental impact of the revised trays decreased by 4.73 metric tons of CO2 equivalents. To further place this into perspective, the reduction of GHG emissions is equivalent from driving from Seattle, Washington to Key West, Florida, 4 times over, which is equivalent to 12,000 miles driven by a passenger vehicle. In terms of other possible benefits, the anecdotal feedback from surgeons and OR staff emphasized improved setup efficiency with the potential for shorter back table setup times. In fact, another study with similar efforts specifically showed quantitative data that decreased setup times with tray optimization. In addition, staff safety in terms of overuse injuries may be positively impacted in that they are now lifting significantly lighter trays. Lastly, reduced confusion was anecdotally reported by OR staff in that through the process of optimization, the trays were reorganized to place instruments in an intuitive order. In conclusion, optimization of surgical trays can lead to streamlined logistics in the operating room and potentially improve efficiency. This study demonstrates that critical appraisal of pediatric surgical instrument trays can result in substantial cost savings and noteworthy reduction in environmental impact. As the healthcare industry continues to grapple with the imperative to reduce its environmental impact, surgical tray optimization emerges as a tangible and impactful initiative that surgeons can champion that aligns with the broader goals of environmentally responsible healthcare delivery. Thank you, and I'm happy to take any questions.
Hi, thanks for that presentation. Great topic. You're preaching to the choir. I'm very passionate about this. Rami Jamshidi from Phoenix. I may have missed this link. Obviously, very logical. It's awesome. Keep doing it and keep going with it. I missed the link between reducing the number of total instruments and instrument trays to the reduction in emissions and cost. Was that an extrapolation based on per instrument, or was that actually calculated by recording the number of instrument tray turnovers and available extra space in the Stericycles?
That's a great question. We spent a while kind of deciding how to quantify this impact. Among the data, we found a lot of reported literature involved by instrument. And this was primarily due to the fact that all institutions have different processes for sterilizing instruments. And there are a variety of ways and protocols and even devices that can be used to sterilize instruments. And so we found this data of 66 cents per instrument and 77 grams of CO2 as kind of a surrogate to quantify these. My goal and dream is to understand our sterile processes specifically at our hospital at a more granular level, but that's still in the works.
That's what I was going to say. You know, the haters will come at us and say, well, you extrapolated per instrument is theoretical. Where's that? I mean, we got people who deny climate change or political environment we were talking about. You know, so
Yes, sir.
we probably got to drill it down a little bit harder, but I love it. Keep going.
Absolutely. Thank you for your question.
Great presentation, Brendan Campbell, Connecticut Children's in Hartford. If you were going to make a recommendation to a center who is just getting started on this work, are there 1, 2, 3 surgical procedures you would recommend that we get started on if we wanted to get the most bang for our buck in trying to reduce cost and CO2 emissions?
Absolutely. I think the most common procedures are a great place to start because, again, you'll have the most bang for your buck and that you perform most of those annually. So I think focusing on laparoscopic appendectomies, which pediatric surgeons perform primarily, is a great place to start. And I think, too, less so focusing on the specific OR procedures, but more so figuring out which stakeholders in the operating room are willing to participate and focusing on those areas, because I think implementation is best adopted when you have folks that are interested and eager to participate.
Thank you.
Thank you, sir.
This will be our last question.
Thank you. Steve Stylianos from New York. Great job. Having been empowered to have these conversations with surgeons over the past few years, one of the typical responses is, I'm totally in favor of this, except don't mess with my tray. How did you deal with the naysayers? Thank you.
Absolutely. That's a great question. Thank you for that question. You know, it's tough. It takes a lot of meetings, a lot of discussions, getting the right people in the room, and I think starting at, for lack of offending someone, I don't know how to say this best, but the lowest common denominator of the folks that are the most strict or the most stringent on what they're willing to give up and what they're willing to change, and making incremental changes from there. So not making too big of changes all at once, starting where you can, and then showing folks, hey, it wasn't so bad when we took away a few of your instruments. Maybe we could make bigger changes from there.
Thank you.
Thank you.
And stay right there. And Dr. Lehane is going to stay right here and talk about From Trash to Treasure, launching a medical device reprocessing program.
So thank you for the opportunity to present again. We have the same funding disclosures. So to address the whys of this talk, we can, of course, refer back to our prior discussion and expand on that by understanding that operating rooms are contributing to climate change by being responsible for 50 to 70% of hospital waste. The rapid evolution of healthcare practices over the past 2 decades has been accompanied by a substantial increase in the utilization of single-use medical devices. While these devices have undoubtedly contributed to advancements in patient care, they have also given rise to this pressing concern of generating significant amounts of medical waste. Medical device reprocessing programs are systematic and regulated processes of collecting, cleaning, disinfecting, and sterilizing single-use medical devices for reuse, and may be part of the answer to this growing problem. So the purpose of this study was to perform a comprehensive evaluation of the implementation of a medical device reprocessing program, specifically at our institution, which is a freestanding children's hospital in an urban area. We launched this program in February of last year. The initial launch consisted of only 2 target devices, compression sleeves and tourniquets. We then further expanded to more device categories such as laryngoscope blades, ultrasonic scalpels, tissue sealers, arthroscopic shavers and abraders, and more by May of 2023. The success of the medical device reprocessing program was driven by robust quality improvement processes fostering collaboration with key stakeholders. A strategic partnership was formed with supply chain, surgeons, and OR nursing to ensure seamless integration. To gauge the environmental impact, a life cycle analysis was employed measuring CO2 equivalents for each item's creation. And to gauge cost savings and projected cost savings, tools from the medical device companies sponsoring the program were provided based on the cost of their devices compared to the cost of their reprocessed devices. The initial months of reprocessing program initiation witnessed a collection of 144 tourniquets and compression sleeves, subsequently declining to a nadir of 60 items over the next 2 months. Expansion of the program to include additional single-use items resulted in an increase in items collected in the month of May, with variable collection numbers after that, but overall an increase in collection of items. Here we have added this orange line, which denotes the cost savings correlated to the items collected. And here we show the added gray line, which represents the CO2 equivalents, or rather GHG emissions, saved each month as well. In-service sessions with key OR staff members correlated with an increase in items collected. In the assessment of the program since its start in 2023 to April of 2024, we successfully collected 33% of all eligible items, generating a total savings of just over $22,000. The reprocessing program demonstrated a reduction in environmental impact through the purchasing of reprocessed items in place of new items. Hospitals can only repurchase reprocessed items or buy back once they've met certain collection quotas for each item. So based on our collection quotas, currently compression sleeves and tourniquets are the only reprocessed items currently in the buyback phase. Even with only buying back 2 categories, we have decreased emissions by 11.28 metric tons of CO2 equivalents. In other words, the reduction of GHG emissions can be described by taking our favorite trip from Seattle, Washington to Key West, Florida, this time 8 times over, or rather driving 28,000 miles in a gasoline-powered vehicle. In addition to the impact of emissions saved by buying back our 2 categories of reprocessed items, the other items currently in the collection-only phase have resulted in 223 pounds of waste diversion. Looking to the future of the program, if all eligible items were collected and bought back as reprocessed, the projected cost savings from the start of the program to April 2024 would have been over $130,000. While we also anticipate a significant reduction of greenhouse gas emissions with the expansion of buyback in the future, precise projections of this aspect are not currently available. In conclusion, the implementation of medical device reprocessing program presents a promising stride that surgeons can be a part of toward addressing the challenges associated with the escalating use of single-use medical devices in healthcare. Successful device reprocessing programs can be green in 2 ways, by reducing emissions and also cost. Stakeholder engagement, particularly among operating room staff by way of in-services, emerges as a pivotal factor for the program's success. Thank you, and I'm happy to take any questions.
Are trocars part of that buyback program?
They are currently in our collection phase, and yes, can be part of the reprocessing and buyback.
Hi, Rami Jamshidi in Phoenix. Again, preaching to the choir, we love it. We're working on some of the same things. One thing I've found difficult, and I wonder if you've had any success with this, is getting information from the processing companies. We'll leave them nameless. We love that they're taking a role in this in the industry, about their energy expenditures and processes, right, that counteract what we may overly estimate or overestimate in our collections, right? What percentage gets trashed and what energy goes into their reprocessing. Have you had any luck with that or tackled that at all?
I have had many, many meetings with our representative of our reprocessing program industry member, and am in the works of trying to figure that out, kind of starting with the low man on the totem pole and working my way up. So I'm hopeful in the next few months that I'll be able to talk with some folks. They primarily point me in the direction of their IT department who makes these calculations, which I don't know if that's the exact right place to start, but I'm hoping to start there and further investigate that. Thank you.
Hey, this is Charisse. I'm a research fellow from Lurie. My question is that you use like QI principles for this project, and I was wondering, like, doing the PDSA cycles, who are like involved with like when you guys go over doing the reprocessing, and like, are we planning to like do further cycles?
Yeah, that's a great question. Thank you. Primarily right now, it's OR staff, so circulating nurses and surgical technologists, as well as the representatives from the industry that sponsor the program. But we're hoping to now get more residents and attending surgeons involved, because they too express an interest in making sure that they're helping to reprocess items, as well as our anesthesia colleagues who were not maybe necessarily aware of some of the things that could or could not be reprocessed. Thank you.
Thank you. For the interest of time, we're going to move on to the next speaker.
Thank you.
Thank you. We will have Charmi Shah, a medical student from the University of Toronto, discussing her talk, There is No Planet B, Operating Room Sustainability Pilot Project in Pediatric Surgery.
Thank you. Hi, everyone. My name is Charmi. I'm a second-year medical student from the University of Toronto, and I'm eager to continue the talks on environmental sustainability within operating rooms. I have no disclosures, so let's get started. So I want to take you back to how this research began by placing you in a clinical scenario. How many times have you finished a case, broken scrub, celebrated for being done, then looked back at the tray and thought, wow, we didn't use or even touch most of this equipment? Well, so did our team. And with this thought, we set out to understand how much of this unused waste, also known as overage, is actually unneeded. And if it's unneeded, can we reduce the overage? So we know that operating rooms are a huge point of consumption within hospitals, and it's our responsibility to strive to minimize our carbon footprint. So this is why research like this is important in making environmentally conscious ORs. We aimed to optimize our instrument and disposable packs so that they actually reflect procedural needs. For our methodology, we studied appendectomies and open inguinal hernia repairs to conduct our waste audit for two reasons. One, they're frequent procedures in a pediatric setting, and two, they're standardized across OR teams and surgeons. And I ask you to reflect on your own practice to think of operations you do regularly that could be up for a similar opportunity of change. For data collection, we looked at our disposable items, and I actually was able to physically collect the waste post-op that was disposable. I categorized it, separated by material type, and weighed it. You could see images on the left-hand side. For the reusable instruments, I couldn't collect them in a similar way because they have to go through reprocessing post-op. So I logged what was being used perioperatively, took pictures of the post-op Mayo stand, and collaborated with the OR nurses and fellows to take post-operative utilization checklists. Equipped with this data, we were able to figure out how we could optimize our trays for these two operations. Ultimately, what we found is that in the appendectomies, both 3-port and Tulas, we only utilize 56% of the laparoscopic disposable packs. And for open inguinal hernia repairs, we're only utilizing 70% of that general minor pack. And if we're actually able to take away everything that's not used and look at what we're saving, we actually annually reduce 480 kilograms of carbon dioxide emissions from plastic material, 36 from paper, and 750 from cotton material. So in total, that's 1,200 kilograms of carbon dioxide emissions reduced. But what does that actually mean? So again, a map diagram. This means that if we actually are able to implement these new disposable packs, it would signify a reduction greater than driving from where we are here in Phoenix to Chicago and back. Now, looking at the reusable instruments, we did a reusable utilization study in appendectomies, one port and single port, so the TULAs, and TULAs utilize only 19% of their instrument set, whereas through port are more resource intensive, utilizing 49% of their pack, or set, sorry. And essentially what this means is that there's a huge discrepancy between these two techniques, even though they're prepared for in the same way. So we created a TULA-specific set that only has 2 out of the 20 laparoscopic instruments, and now that's in rotation at our institution. And for our general minor set that is used by all appendectomy techniques and open inguinal hernia repairs, we found that around 50% of the items are going unused, and there's an overlapping 48 to 50% that are being used in all 3 procedures. So we created a new inguinal hernia API set, nicknamed the Happy Set for all of its savings, and it's currently in rotation as well in our institution. And with these 2 new sets, we actually reduced 28,000 instruments from being unnecessarily washed per year. So in conclusion, you can see that reducing and optimizing our instrument trays and disposable packs has a great carbon dioxide emission reduction, but it's also financially beneficial. And this is highlighting a great opportunity for green surgical practices. We recognize this is very resource intensive. Waste audits require time and manpower, so we want to figure out how to streamline this using AI and technology. We want to collaborate with other subspecialties and create a model to actually quantify our complete organizational impact. And we're excited to see how our work leads us and the impact we make on other ORs, hospitals, and the greater planet. Thank you so much. And special shout out to Dr. Fecteau and Dr. Ramjes for all their help. I'm happy to take questions.
I think in a lot of the hospitals I work in, the packs are actually bought as a whole pack.
Right.
So you're creating your own packs that you're not purchasing from an outside source. Is that, what's that?
Yeah, I think with most hospitals, you buy externally, and that's the same at the Hospital Sick Kids where this research was done. And we buy from Medline. So the work that we do here, we're able to show consistently that this is not being used, and we want to create a new pack. And they've been really eager to also help us implement this change, and we're working with them right now to do that.
Oh, that's great work. That's awesome.
Hi, Christine Velasco, Arnold Palmer in Orlando. Great project. Do you use peel packs for any instruments that sometimes the surgeons might need? And then how do you prevent the OR from losing them? I have a couple instruments I use since I've been attending 1.5 years, and of the 3 sets, they've lost 2 of them because they're peel packs. And how do you prevent that from happening, and when a surgeon needs something extra that might not be in the minimized kit?
Yeah, that's a great question. We use peel packs at Sick Kids for just-in-case items. So if surgeons need more instruments, we're able to peel more instruments that are sterile. For our trays and packs, the packs come externally, and the instruments actually come in their own trays. So it's not likely that anything will be lost in that sense. But we are looking into peel packs specifically for the surgeon variations. So for example, in hernias, there are some surgeons, or 1 or 2 in our institution, that like using a hernia spoon, which is not very common for other surgeons. So we make sure to have that in the pick list ready, so they use this new reduced set, but also a peeled pack for a hernia spoon. That's the way we're kind of going about it.
You did a great job as a medical student also. Congrats.
Thank you.
Yeah.
Thank you.
Rami Jamshidi from Phoenix. Yeah, same thing that Dr. Velasco just said. Thanks for coming as a medical student and presenting to us and taking on a topic that isn't widely accepted, but probably, you know, the higher up your birth year goes socially, the more interest there is. So I think that's awesome, and I'll throw out a plug that I think those of us who are interested in this realm should get together and chat at other times. Along the lines of Dr. Yoder's question about the fact that packs come preset, right? There's a standard like value meal #1 that you order, and the fact that the people with the purse strings don't necessarily care about our social values, but want to know what are the dollars and cents. So it's cheaper to get the value meal at $5.99 than to say, I just want the burger and fries and pay $7.99. Did you guys tackle that at all, or is that different? I'm guessing it's not different in the Canadian system, but
Yeah.
did you tackle that at all?
A great question, and I agree that we should collaborate more for people who are interested. For the question, we are actually doing this work with our external resource for our disposable packs to see if there is a saving. How it works for disposable packs is that every change you make, there's a little bit of a fee that you have to pay, and then they make that change with that reduced set. So we're doing a cost analysis to make sure that it is beneficial, and so far from what we've seen it is. I just don't have the final values to present today. And in terms of the instrument trays, there is financial savings there as well that we want to quantify with our math model in terms of water savings, chemical savings, energy, labor costs. So that's what we're trying to put together in a concise way to actually go to a hospital and be like, we should be doing this for all operations. Yeah, thank you.
Thank you.
Awesome.
Our final presentation is Claire Juhas from University of Texas. Let's talk about it, firearm injury prevention training for medical students.
Hello, I'm Claire. We have no conflicts of interest to disclose. So, as we've talked about, firearm injury is a growing public health crisis in the United States, and it became the leading cause of death of children in 2020. Conversations with patients and their families about firearm injury prevention have been shown to increase rates of secure storage, and increased secure storage is linked with decreased rates of firearm injury. However, most physicians are not routinely engaging patients in these conversations. One cited reason for this is lack of education, as firearm injury prevention is not routinely integrated into undergraduate or graduate medical education. Our team saw this gap and wanted to implement a solution. We hypothesized that medical student perception, knowledge, and comfort about these conversations would increase after education. Our project included a pre-intervention survey, a 30-minute educational session, and a post-intervention survey. This was conducted at an academic institution during third-year medical student didactics, and our institution has a level 1 trauma center, and we serve a large catchment area with both rural and urban populations. Firearms are a prevalent problem for our patients, and we admit an average of 1.5 per day for firearm-related injury. Additionally, the number of children admitted for a firearm injury at our institution has doubled since 2018. Our curriculum was adapted from free tools published by Bullet Points and Be Smart, and we highlighted counseling strategies, legal knowledge, and local and national resources for firearm safety. Over the course of one academic year, 100 students completed our pre and post surveys. Among those students, 29% resided in a home with a firearm. Of that, 21% reported triple secure storage of their firearm, 58% partially secured their firearm, and 21% left their firearm unsecured, which is thankfully better than the national average of about 30%. At our institution, all students complete shifts in the trauma bay during their surgery clerkship. And 97% of our students reported treating a patient with a firearm injury, the majority of those being from community violence, followed by unintentional discharge. Additionally, our students identified firearm safety as an important issue to our patients. Some barriers for firearm injury prevention counseling reported by students included time, confidence, fear, and not my lane. Our students also had limited education with providing firearm injury counseling to patients. Only 4% of students had been provided with any formal education on counseling. As much of surgical education happens outside the classroom, we asked if students were exposed to firearm counseling in the wards, and only 5% reported ever seeing healthcare providers routinely counsel their patients. Do one, see one, teach one is not occurring. This lack of education is unfortunate because 81% of our students reported that they would be more likely to screen patients for firearm safety if they received more education. Bridging this gap is an important intervention. After training, reported comfort increased significantly, with 76% of students stating that they are comfortable or very comfortable engaging patients in conversations about firearm safety. 70% said that they were likely or very likely to change their practice based on what they learned from our training, and 87% reported our training was useful. Furthermore, our training improves student knowledge of laws related to firearm safety counseling. Knowledge of general laws, child access prevention laws, and red flag laws all increased significantly. We also asked more open-ended questions to capture how students felt about firearm injury prevention conversations, both before and after education. You can see shifts here. After education, more students felt that conversations were important, many more felt that they were essential, and less felt that they were awkward or cumbersome. While we felt that this project represents a successful and easy to implement program, we acknowledge that our data are not without limitations. This is a single institution study in one geo-socio-political location. The survey questions used were part of a pilot project, so they have not been validated across larger audiences. And medical students receive this education at various points throughout their third-year clerkships. Despite these limitations, we think our sessions represent an easy to implement, low cost, and effective intervention that may increase firearm safety counseling. Our training is now a regular part of our institution's MS3 didactics, and we plan to continue this in the future. We've also provided this education to various residencies and departments at our institution. We would like to partner with various organizations in our community to expand our reach. And with these lofty aspirations, I thank you for your attention and welcome any questions.
Go ahead.
Hi there, my name is Amelia. I'm a medical student as well at the University of Cincinnati. I was just wondering, you have this implemented in your MS3 didactics, and is it in surgery or is it just your first didactic of the year? Because at Cincinnati we have it something similar, not to this scale, certainly, but in our pediatrics rotation.
So it's in our surgery rotation, and before we implemented this, our institution didn't provide any firearm injury prevention training at any point. So this is the first year of students at our institution being provided this education.
That's awesome, by the way. I think your presentation was great. Do you think that there's any utility in putting it earlier in MS3 before surgery or in the preclinical years, or do you like where it is?
It could be useful in preclinical. We do have an injury prevention lecture then. Firearm injury is not mentioned in that lecture. And so we worked on this with trauma surgeons and pediatric surgeons at our institution, so breaking into surgery didactics was the easiest way to start providing this education.
That's awesome. Thanks so much.
So, Chris Newton at UCSF. So, I love the program, and I love the comment about can you get it in earlier? Because while I appreciate the product, I want more. I want fire injury prevention. I want expert training, and I want training on screening for mental health, and I want training on what is social determinants of health, and we could go on and on. So how is there a vision of implementing and putting it all together in a med student training program before you get to your third year?
Yeah, so at our institution, we do have a 6-week block that's focused on medical humanities, and we do focus on a lot of social issues like that. Unfortunately, firearm injury has not been added to that curriculum. We do want to reach out to our medical ethics program at our institution to try to get that added.
That's great. Thank you very much. That's awesome.